Good afternoon, everybody. Welcome to the second CME of the College of Rheumatology and Rehabilitation for this February. Today we have two lectures lined up. First one will be done by Dr. Hashan Senarathna. He is the consultant in Rheumatology and Rehabilitation in the District General Hospital, Mannar. He's talking today about idiopathic inflammatory myositis. Is it paraneoplastic? Over to you, Hashan.
Good afternoon, everyone. Thank you for kind introduction, madam, and giving me this opportunity. Today I'm going to discuss a small yet an important guideline with regard managing idiopathic inflammatory myositis. So first I would like to go through a small case history of one of my patients. This is a 37-year-old female teacher from the state sector who presented the features of progressive myositis, features of progressive myopathy rather, for last 3 years duration, and the rest of the history is unremarkable. On examination, she was thin built with a BMI of 18, and mainly the power of thigh muscles were 4 out of 5. Mainly in the hamstrings, and there is generalized muscle tenderness, and rest of the examination is unremarkable. For the first presentation, my differential diagnosis was initially the fibromyalgia, because I have seen many patients with fibromyalgia when I was in the UK, and the features are typical, so I thought this patient could be having fibromyalgia. And my second differential diagnosis could be metabolic myopathy, like the hypothyroidic associated myopathy. And my third differential diagnosis, immune-mediated myopathy, because I am not a serious guy to diagnose the inflammatory condition at the first presentation. But I'm wise enough to add inflammatory condition in my differential diagnosis, not to miss anything. And there could be anything other things which present same. So I asked patient to come the next week with the investigations. When I reviewed the investigations, ALT was 60, rest of the liver biochemistry was normal, and CPK was not much elevated, 1070, and ESR is 43. Vitamin D level was 10, which is low, and rest of the basic investigations were normal. You can see TSH level is normal, and serum electrolyte was normal. Even CRP level is normal. So we have a patient with a young female present with a slowly progressive proximal muscle weakness without any other complaints. As I mentioned before, CPK was not much elevated, vitamin D was deficient, and ESR was 43. So head of the coin, I could have missed ESR 43 disregard, and CPK was not much elevated, because if it is inflammatory myositis, we expect to see few thousands of CK elevations, but CPK is around 1000, means it could be a metabolic myopathy, and I could have replaced vitamin D with high dose with supplement and monitor the patients. But what's the other side of the coin? Sorry, the wrong coin. I cannot explain the 43 of ESR without any explanation, rather inflammatory conditions. And sometimes, particularly in inflammatory myositis, CPK may be not high enough to identify it, particularly in neoplastic conditions. And so at that day, I go ahead with the rest of the investigations. I asked ANA. ANA was 2560, and rheumatoid factor was high. And same day, I asked my surgeon to have a muscle biopsy. And here you can see the biopsy, what you can see. Actually, I'm not a pathologist, so I went to the pathologist to explain, to get an explanation for this. And she explained me that this she can see the myofiber size variations with internalized nuclei and endomysial lymphocytic inflammation surrounding and invading non-necrotic myofibers, few plasma cells, and macrophages without evidence of perifascicular atrophy or rimmed vacuoles, which is compatible with myositis. I would like to take your attention for a few words here for the juniors, because this may relevant to your exams. So there is no features of necrotic myofibers, which is a feature of necrotizing myositis. And there is no evidence of perifascicular atrophy, which is again a feature of dermatomyositis. And there is no rimmed vacuoles, the feature of IBM. Right. So this is compatible with polymyositis. So we went through the antibody profile. Initial dsDNA was negative, and from ENA panel, anti-LA and anti-Rho was strongly positive, and from the myositis panel, only Rho 52 was strongly positive. So I have included other antibodies from myositis panel, which we have checked and came as negative. So these the expensive investigations were arranged by the Candy team, kindly, because we have not facilities to arrange these kind of investigations in my unit. So we have young patient present with the slowly progressive proximal muscle weakness without any other complaints. And as I mentioned before, CPK was not elevated, and ESR was mildly elevated, 43, and muscle biopsy shows polymyositis. Rheumatoid factor was positive with the ANA, highly positive, and anti-LA and anti-Rho was positive, and from myositis panel, anti-Rho 52 is positive. So at the end of the day, this could be very well overlap myositis, or we call it CTD-associated idiopathic inflammatory myositis. And even rather, we could say this could be undifferentiated connective tissue disorders, because there is no other features of connective tissue disorders. However, we arrange organ screening. Her 2D echocardiogram is normal without features of any pulmonary hypertension. Lung function test and HRCT does not show evidence of interstitial lung disease. And because her anti-Rho and anti-LA was positive, we arranged a labial biopsy which does not compatible with Sjogren's syndrome. So big question is why this patient present with these features of polymyositis without any other connective tissue disorders. So my question is it paraneoplastic? So what are the things it could be the highly likely paraneoplastic from the audience? Hands up who thinks this is highly likely of paraneoplastic syndrome? Who thinks no? Few answers. Okay. For me, it's a puzzle. So is there any tool to decode this puzzle? I checked, and we learned from this guidelines. So IMAX initiative recently, in the recent past, published a guideline to, it's a guidance to use in this situation, particularly in our country, the resource poor settings, whether we can go for expensive investigations or not in managing inflammatory myositis to hunt for malignancy. So I will, the rest of the talks mainly based on this guideline and its evidence. And they say it's adult onset immune myositis is associated with the increased risk of cancer within 3 years of before diagnosis and 3 years after the onset. So this is highly important, because 1 in 4 people with myositis, immune myositis, are diagnosed with cancer within 3 years of the diagnosis. And most common form, the lung would be lung, ovarian, colorectal, lymphoma, breast and nasopharyngeal cancers, particularly in South Asian population. So early detection of cancer improve the outcome. So we need to find out whether there is a cancer or not. So how would we do that? So they have 18 recommendations. So first three, it's important to, it is easy to remember. IBM and juvenile myositis could not associated with high risk of malignancy than the general population. So you don't need to do the screening test for these patients. And irrespective of diagnosis of inflammatory myositis, you need to participate. You need to get participated these patients to this country or region specific cancer screening programs. As example, this lady should have undergone pap smear according to national guidelines without irrespective of diagnosis of inflammatory myositis. So how to stratify cancer risk? So key investigation to perform is myositis panel. There are, as you can see previously, the mix of myositis antibodies were included in this myositis panel. So there are two types of antibodies, myositis specific antibodies and myositis associated antibodies. I believe you are aware of these words. And myositis specific antibodies are highly specific for myositis. That means presence of this in the blood indicates there is ongoing process of myositis most probably. But presence of myositis associated antibody does not say so, because even this antibody present in the patient's blood, it does not mean the process of immune myositis is going on. So it may present without any features. And sometimes this antibody dictate the clinical phenotype, like MDA5, presence of MDA5, meaning it's patient probably having rapidly progressing ILD. And MI2, presence of MI2 possibly having dermatomyositis, which is well responded to immunosuppressions likewise. Then, according to subtype, IIM subtype and antibody level and clinical features, you can categorize, you can stratify the risk actually. So from the literature, they have found out risk factors, and they have categorized these risk factors into three main groups: high risk factors, intermediate groups, and low risk factors. Then what they say, if you have two or more high risk factors in your patients, that patient belongs to high risk category of having internal malignancy. As an example, if your patient has dermatomyositis and dysphagia with anti-TIF1 gamma antibody positivity, that means this patient is probably having cancer. You need to hunt for that. Yeah. And if you have one high risk factor or two or more intermediate risk factor, those kind of patients has more moderate risk of having an internal malignancy, and rest of the people belongs to low risk of having malignancy. Right. If you need words, here you go. So what next? So we did the stratifications, and management would be different for each category. If you have high risk patients, you need to screen at the time of diagnosis by using basic and enhanced screening panels. I will tell you in a minute what are these basic and enhanced screening panel. And you need to do basic screening panel at the end of first, second, and third years annually for 3 years. And you need to consider additional screening test if it is more suggestive of malignancy. Even basic and enhanced screening panels are negative. If patient has a moderate risk of this having paraneoplastic myositis, you can do screening at the time of diagnosis by using basic and enhanced screening panels, but there is no need to do follow-up screening. Other patients who belong to this standard risk, you need to do only basic screening panel at the diagnosis and no need to do the repeat investigation annually like in other groups. So basic investigation, basic screening panels includes history, physical examination, and full blood count, serum liver function test, ESR or plasma viscosity, CRP, and serum protein electrophoresis, urinalysis, and plain chest X-ray. And enhanced screening panel, sometimes you need to do the CT NCAP, that neck, chest, and chest, abdomen, and pelvis, and cervical screening, mammography, prostate-specific antigen, CA125, and ultrasound of pelvic and transvaginal to exclude ovarian malignancy, and fecal or gall blood. This enhanced screening panel to be done if it is not done under your this age and demographical, what do you call it, age-related screening test under your local guidelines. Right. So this is what I explained. And if you didn't understand what I said, you can read it. So what are the additional investigation we need to do regarding these patients? And they said clinician should consider carrying out this PET-CT scan for patient with adult onset inflammatory myositis at high risk of this myositis IIM related cancer, where underlying cancer has not been detected by investigation at the time of the diagnosis, as I mentioned earlier. So unfortunately, we can't afford for this PET-CT even in the government sector because the long queue. So we need to rely on our clinical instinct with the history examinations and the basic and enhanced screening tools. And then they said the clinician should consider carrying out this PET-CT as a single screening investigation for patient with anti-TIF1 gamma antibody positive antidermatomyositis with disease onset at or more than 40 years and with one more additional high risk. Because they said we can skip all these basic and additional basic and enhanced screening tools if they have high risk of cancer, because the literature says anti-TIF1 gamma antibody could be positive in with the malignancy about 70% of the some cohort, and that means the risk ratio is 4 times. That's 4. That means 4 times higher to have malignancy when compared to other patients with myositis. So anti-TIF is a very nasty antibody to have, and it related to paraneoplastic myositis. And they said carrying out upper and lower GI endoscopies for the patients with adult onset IIM at the high risk of IIM related cancer, where underlying cancer has not been detected in investigation at the time of diagnosis. That means if you fail to identify malignancy by using enhanced screening tests, you need to consider upper GI and lower GI endoscopies. And they also mentioned the nasoendoscopies to hunt for malignancy, particularly in certain geographical areas like Southeast Asians, because they have higher risk of this nasopharyngeal cancers and associated paraneoplastic myositis. Apart from that, as a clinician, you need to understand these red flag signs like weight loss, unintentional weight loss, family history of cancer, smoking, unexplained fever or night sweats. If one of these present in your patients, then irrespective of this categorization, you can go for enhanced screening. So if we come back to our patient again, these young patients present with slowly progressive proximal muscle weakness without any other complaints. As you are well aware, CPK was not much elevated. ESR was 43, and muscle biopsy is polymyositis, rheumatoid factor positive, ANA positive, anti-LARO positive, anti-Rho 52. So still it could be overlap myositis or the CTD associated myositis, but you can see BMI was 18. It's a low BMI. So we cannot disregard these factors, or still it could be paraneoplastic syndrome. Problem is he's from estate sector. They usually thin build. So I repeatedly asked whether they have measured the weight, but she said no. And currently we are monitoring the weight, and we have done additional investigations like ultrasound scan of abdomen and pelvis, and ultrasound scan of the breast, and other possible investigations, but we couldn't find any feature of malignancy of these patients. If patient is not responding to our treatment or further losing her weight, then we need to think about other investigation. At the moment, we are managing as overlap myositis. Thank you very much. And I would like to thank my patients and my team from Navalapitiya Rheumatology unit. And I would like to special thanks to Dr. Eleni Satapolo, who is my trainer at the UK, who discussed this myositis case from my training beginning in the UK. So I discussed this case as well. So she enlightened me regarding this paraneoplastic syndrome and all those guidelines, and give me the point for this lecture as well. And I would also like to thank Dr. Utpala Disanayaka and her team for arranging these investigations. Otherwise, this could not be possible. So if you have any questions, I would like to answer.